Up next we have Kei Ouchi from Brigham and Women's, here to talk about goals of care.
Hi, thank you so much for the opportunity. My name is Kei Ouchi, and I'm an emergency physician and home hospital physician at Brigham and Women's. And today I'm going to talk about goals of care conversations. So if you worked in ED, you may have run into a patient who is someone like him. He was an 82-year-old gentleman with history of metastatic lung cancer with pleural effusion coming from home hospice to the ED for hypoxia and hypotension. And I'm sure if you're a practicing physician, you may have noticed family members could be just intubate him. And you are thinking in your head, what is going on? Why don't they know that he is dying? And you are thinking, what's the best thing for you to say? The fact is, patients know that they have more important things other than living as long as possible. And most patients find other things like pain or financial issues more important. And also, most patients don't get to talk to their caregivers or physicians about what they want in their end-of-life care. And no one has basically a documented wish to let us know in the emergency department. And we also know that 70% of patients who may die, they choose to die at home, but yet only 30% in our country die at home. So it sounds like patients know what they want, but we don't really provide that. And if you think about, maybe they don't know that intubation is not that great. Well, actually, intubation has 35% overall mortality rate for older adults. And it seems like a knowledge that we should all know, but maybe we're not communicating that very well. And most patients who are older and getting intubated in ED, they die if they're going to die, they're going to die in a matter of days. And even after they survive the hospitalization, patients who are intubated have much, much higher chance of dying in the next 30 days or 1 year. And most importantly, their physical function goes down almost inevitably. So if they had moderate disability, only 30% chance of maintaining that function. So do patients and families understand that? Like, where is the gap? And I thought about my grandma, who's pictured in the middle. This was when I was a student, and she used to always say things like, I want to die real quickly. I may not be able to see you next year when you come. But yet she died in a hospital on intensive care unit for 1 month, unresponsive. And I've seen how people have done great conversations to try to lead patients into getting the care that they want. And there are best practices for how to do this in other settings, like the Serious Illness Conversation Guide or the communication trainings. But what's the best way to do this in the emergency department when it's so difficult because of acuity? So I would propose that you prep the room and prep your team to maintain how the patient is without intubating or any other invasive interventions while you go have this conversation. And I'm going to term this conversation crisis communication. And first of all, you tell patients, I'm very sorry to see you like this in this way for your dad. And we have an urgent decision to make, and there's a lot of unknowns. And tell me about how your dad would have wanted to be cared for. And there's a specific step to do that. And when the caregiver says, why can't he be intubated? He doesn't mean that. What he means is he's short of breath and you need to help him. And we need to respond to their emotions rather than responding cognitively with statistics and numbers. And when you feel stuck in this conversation, tell me more, or asking them about their values and preferences are always good to do, because they will allow patients to have the time to process their emotions. And ideally, most patients would have prognostic awareness and clinical status aligned, but often the patients we meet are not, and our job is to get them to see how sick they are. And this communication skill, I used to think that these palliative care clinicians are really born with it, but it's just a learned skill that we can all acquire as clinicians, and especially important in the emergency department. So I think having this conversation well can change patients' course, and We are the only physician who can manage the hypotension, hypoxia, and also lead them to the care that they want. And we should own this conversation.
Thank you very much.
Call Diane. Diane, please come up. Hey, judges. Not working?
Hello. So thank you for the excellent presentation. I think the part I enjoyed about it the most was the first 3 or 4 slides where you talked about the disparities between what patients want and what they end up getting and what patients' wishes are and what they're more concerned about. For me, that was a real eye-opener. And I think some ideas would be helpful, like how to specifically, beyond sort of the generalities of patients' wishes and trade-offs and how they feel, the specifics of how you put yourself in their place and how you can bring that knowledge and those statistics of the cultural knowledge and the disparities between what people want and what they get, how you could bring that into the conversation. Thanks.
Thank you so much.